What inspires someone to become a surgeon? And what's it like to have a job where kind of day in and day out you're talking about cancer with your patients? Welcome, GynoCurious listeners. I am Dr. Amy Novat. From both sides of the speculum, we are here to talk about what it means to be a healer and to be healed. Today, I want to welcome Dr. Zoe Weinstein. Zoe trained as a general surgeon and now specializes in surgery for benign and malignant breast conditions. Zoe trained at the Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx, and currently works for Health Alliance in Kingston, New York. Welcome, Zoe.
Thanks for having me.
I'm so glad you're here with me today. When people ask me about Dr. Weinstein, the first thing I say is, she's a real New Yorker. So tell me, where are you from? I think you're from New York.
So I grew up in Far Rockaway, which is in Queens. I lived my whole young adult life in New York City. And then I moved to the Hudson River Valley about 20 years ago.
Yeah, like so many of us, we make that move from the city to the country.
That's right.
Yeah, it was a good one for you?
Yes, I think it's very hard to take care of patients in these busy academic centers if you're really committed to direct patient care and being in control of good surgical outcomes. There are a lot of variables. And I really wanted to get to a place where I thought I could have more agency over patient outcomes. So for me, it was a really good decision.
Oh, great. Yeah, and for me, it also was about community. In the big city hospitals, I just never felt really like I was a part of a whole organism. There were bits and pieces and people with whom I had relationships with, for example, the radiology tech or the pathologist. So there were individuals with whom I overlapped or interacted with on a regular basis, but there wasn't the same sense of community that I have felt working in this smaller area or smaller hospital setting.
I agree with you. One of the problems in the city was I felt so connected to my patients in the Bronx, but I had such a hard time getting the other people who worked in the hospital to be as committed to them. And it was really emotionally exhausting to navigate the health of these patients against the current of people not caring as much.
Yeah.
So that it was actually tough to leave.
So were you inspired to become a physician because there were docs in your family?
No, neither of my parents graduated from college. My father died when I was very young of rheumatic heart disease, which is a problem that people don't have now because of penicillin.
Yeah.
I'm the last of 5. My parents were born closer to the turn of the century. I didn't have a lot of access to healthcare when I was young. I went to clinics. Sometimes people saved up money to take me to the doctor. So I would have to say that I became a physician because I felt personally as though physicians had reached into my life when I was young and helped me survive. And I thought it was a worthwhile profession.
Did you feel there were many obstacles for that pursuit along the way?
Absolutely.
Yeah.
It's what everyone is much more comfortable talking about now.
Yeah.
About when you don't have a lot of money, you don't have family members that went to the same schools, you're not a legacy type of student. You don't have you have food insecurity, all of those things that people really talk about now in college and high school and in getting their advanced degrees. I experienced all of those things, and it really interferes with the average person becoming any kind of professional in this country, and it's a serious problem.
Yeah, and then the encumbrance of paying for medical school or professional school.
Oh.
And that you and I know that folks will pick a high-paying specialty like orthopedist, for example, because that's the only way they see paying back their loans.
Yes, even after I became a surgeon, I was surprised to hear that medical students with high debt burdens after medical school choose surgery. I don't remember that being part of my calculus, but it must have figured in someplace. In a deep way, I doubt it because I didn't go into one of these high-paying surgical subspecialties, but it could be that it does factor into your decision-making, again, affecting how disadvantaged students end up in different careers in medicine where they may not even want to be or where we may not need them. For instance, we need a lot of primary care physicians, but we know that those people are not paid well enough.
Yeah, the fee schedules are upside down. You know, why we're putting hips in 95-year-olds and paying a lot, or orthopedic surgeons are being paid a lot for it, and yet we're not paying the doctors who are taking care of diabetes and heart disease and preventive care.
Absolutely. We don't know. I don't know who made these reimbursement schedules, but if you were home in your house thinking about it, which I have been many times, you think there were 100 white guys at the table and all of the people of color and the women were in the hospital in the middle of the night fixing somebody while these guys who played golf together decided who should make the most. And we're stuck with that.
Yeah.
And no one even wants to talk about it.
No, because some of those same fellows are sitting in the boardrooms of big pharma and large medical companies and government, right?
Absolutely.
Yeah.
And how many times are there patients who've undergone some extremely expensive elective orthopedic case where myself or some other provider has been called to the bedside that they have an undiagnosed advanced breast cancer or mass on their abdomen or their blood sugar is 450. So you know that there's a way to funnel these patients into these expensive operations and the path of maybe getting them food sent to their homes that are healthy to get them to lose weight so they don't need a joint replacement. Those avenues are completely experimental. Those are only grant-driven programs that no one has bought into long-term.
Yeah.
It's a problem.
This is very tangential, but it reminds me of an article I read this morning about the multi-millions of dollars that are going into the arena for the Super Bowl. And no one is putting these public funds towards education and children in Nevada and Las Vegas.
Absolutely.
Yeah, same problem.
Or even advertising for food in restaurants. I don't know who's getting these spots for the Super Bowl, but we know that all of these advertising campaigns that promote processed and unhealthy food are directly contributing to this leading problem in the United States, which is morbid obesity, which increases the rate of cardiac death, cardiac morbidity, and cancer.
That's right. That's right. Yeah. Oh,
It's
just
tough.
want to take a big sigh.
Yes.
So let's go back to perhaps days that were filled with more idealism. So, you know, when I was a resident, when I back up, when I was a medical student and I did my surgical rotation, there was one woman amongst, I think it was 12 or 15 surgical residents. And man, she got so much shit and hassle during her residency. What made you decide to do general surgery, and was gender an issue when you were training?
So this is an interesting story. I really thought that I would go into psychiatry or gynecology. And when you're a third-year medical student, you go through these rotations, and you load your rotations in the beginning of your third year, going into the ones that you really think you're going to want to be in so that you can figure out for your fourth year what electives you want to do so that you can really flesh out where you're going. And I did an OBGYN rotation, and I really felt that the residents were just did not care that much about the women and weren't feministic enough. For instance, I liked taking care of the women, but I felt no sense of community with these other residents. And so I felt I didn't belong there. And then when I did my psychiatry rotation, I was briefly in an inpatient ward with paranoid schizophrenics, and I felt extremely anxious. And I thought, I'm not going to be able to do this.
Where was that rotation?
That was at Bronx Psychiatric. So I think that part of what happens when you're a medical student is that you have these ideas, but then in real time, they just don't jibe with who you are. And what did I choose to do last? Surgery, because I knew I was never going to be a surgeon, right? I'm not going to be with a bunch of arrogant white guys who think they're God. Truly, right? So it's my last rotation. Did you ever know this?
No, I didn't know this.
It's funny.
Yeah.
So I did it at like the worst place to ever get a residency spot at Long Island Jewish, even because it was part of Einstein, but it was like a remote hospital.
Right. In those days.
That's right.
Yep.
It was, even though now it's part of Northwell, which is a monster, right?
Yeah.
It was just a little community hospital.
And remind me what year we're talking about. When were you a third-year medical student?
It was 1993, so it was a
Okey-dokey.
long time ago.
Yeah.
I would take this taxi from the Bronx with the other surgical students, and my first rotation was vascular surgery. And one of the first patients they had me interview was like a middle-aged smoker who needed a below knee amputation. And I just loved this woman. I remember her name today. And I really bonded with her, and I did her history and physical, and then she was going to have her amputation that day. And I stayed. And I did this, and, you know, they draw the line around the skin of the leg below the knee, and they drew the line, and they had me make the skin incision, and the chief...
Wow, as a student.
That's
wow,
right. And
that's
the
impressive.
chief of vascular surgery was there, and the resident was there, and we did this case, and the leg came off, and Dr. Cohen, who was the chief of vascular surgery, said to me, "What do you think about that?" And I thought, I don't give a shit what this guy thinks. I'm never going into this field. This is so depressing. I'm so depressed.
Oh, my gosh.
And I said to him, I think it's the most depressing experience I've ever had. And he said, that's right. That's right.
Wow.
And
how honoring.
It
It's so
was
unexpected.
It was so weird.
Yeah, yeah. I would have thought the answer was going to be some bravado,
That's
but
right,
he was empathic.
Right. Suck it up, pal.
Right.
This is the way the world is. Or it's not so depressing.
Right.
She could have her whole hip disarticulated.
Right,
Now,
right.
when you think back, no. And he was like, absolutely. This is a wonderful patient who's been smoking her whole life. And this is just terrible. And I
Yeah.
thought, these are my people. I had this
Wow.
feeling like, these are my people. Now, the problem was that all of these guys who were residents there were just an endless stream of entitled white guys. So then I spent 3 months with them, and I saw all kinds of operations, and they let me scrub in on everything. And it was just, I am someone who never gets tired of looking into the abdomen or looking into the thoracic space. One of the last cases they did was an esophagectomy, which at that time...
Just remind the audience what that is, please.
We removed the whole esophagus for cancer. So we're opening up the chest and the abdomen. We're looking into the thoracic space, into where the lungs and the heart live. And we're also looking into the abdomen because we take out the esophagus and we have to pull the stomach up into the chest.
And these were the days where you made a large incision, right? None of this was laparoscopic.
Or robotic or
Yeah,
anything. So
right.
they were huge cases. They
Right.
were very dangerous for the patient.
Yeah.
They took forever.
Hours and hours
They were
and hours.
associated with a high complication rate. And we were there for 11 hours. And the whole time I was retracting the lung
Oh,
because
my
it was in
gracious.
the way.
That
with
means
this-
pulling it. Go ahead.
just gently holding the lung, which was soft and pink and inflated, and made this very quiet breathing sound the whole time, like a little squeak. And I was just happy the whole time. And I really always describe it to people as like falling in love with the wrong person. That's what it is. It's like, you know that this guy is the bad guy. Like, you should definitely run in the opposite direction.
And the
but
guy being surgery.
Yeah. But you're like, what can you do? You just feel you're happy. It's collaborative. You can see the anatomy. You're planning on what you're going to do. You're understanding an underlying metabolic problems. It just was the right thing for me.
Oh, I love it. You are describing love.
Yeah.
And you're describing being enthralled, which is what we hope for anyone who's pursuing any career.
Anything.
But certainly when it comes to medicine and you're caring for people and the system is broken and all kinds of obstacles, that if that love can carry you through, it's
what
such
we
a
tell
blessing.
all people. I say all jobs are the same.
Yeah.
You're going to be at work every day wondering, why am I here?
Right.
Why am I doing this?
Right.
This person's an asshole. No one's helping me.
Right.
I'm exhausted. I
Right.
was up all night. My baby's right. Whatever it is.
Right.
There has to be something in whatever that job you're doing that you just say, I can do it. I
Right.
can get through it because this is important.
Yeah, it's something I remind my kids. There's a good part of any work that's just labor. It's
Yes.
just hard. And hopefully, as you point out, what carries you through or keeps you coming to the office every day or wherever you go for your work is the mission, is the love, is the understanding that what you're doing is contributing.
Yeah. And I
Yeah.
think we have to remember that sometimes there are people who are working really because they have to support their families.
Yeah.
And it's really okay for that also to be the kernel of what
That's right.
drives you.
That's right.
Because everybody can't get these degrees where you can specialize in something that has a deeper meaning to you. Sometimes the deeper meaning is just being able to be in your own life in a meaningful way for yourself or whoever you're connected to.
Thank you, Zoe. That's so important. So the passion isn't necessarily with the work, but the passion is around supporting your family. The
Yes.
passion is around allowing you to, I don't know, bike
Get-
ride each weekend because that's your pleasure. Absolutely.
Sometimes people are really working to give some small donation every month or week to a charity that's important to them,
Yeah.
or bring a bag of dog food to the shelter that they're volunteering at, or have enough money to do the extra wash for that shelter. I just think it's a big picture.
Yeah. Thanks. I appreciate that perspective. So as a woman, in the face of all those residency, did you face a lot of challenge, or were you just bold and knowing that this was what you wanted to do and you just pushed through it?
No, I wasn't,
Yeah.
because what happened was in my last year of medical school, at the end, after my surgical rotation, my mother died. And then the next thing I was going to do after she died was an elective in pediatric surgeon at LIJ
Oh,
with this really famous pediatric surgeon whose name is Alberto Pena. He was someone who designed these very complicated operations for children with anorectal malformations.
oh, gracious.
Children born without anuses, children whose rectums are attached to their bladders. And he was trained in Mexico, and Mexican pediatric surgeons first did pediatrics, a full pediatrics residency, and then they did pediatric surgery,
Whoa.
which is a totally different kind of training because it meant that they were doctors for children and then surgeons for children. Very interesting. And he was incredibly talented. And he actually traveled all around the world teaching residents and surgeons in other countries how to perform these operations. I did this rotation, and I tried to spend lunchtime in the residence room with the slew of white guys. And I said, if I can survive in this room with these guys, I will do my surgical residency. And one day they were in there telling each other how there was a woman in the ER with acute appendicitis. And one of the other guys said, does she have nice tits? And I said, fuck this, I can't do this. So I did a year of pathology. I couldn't do it.
Yeah.
I thought that's what it was going to be.
Yeah.
5 years of being with these guys. And I wasn't in a great place because my mom had died.
Sure.
And I just didn't think I could do it. So I didn't do it. And then I went to Montefiore to start my surgical pathology residency. And then all the Montefiore residents were there. And they were Black, and they were Indian, and they were female, and they were white, and they were all different sizes because they used to come to the pathology lab to check on their specimens, to check on their pathology. And I thought, maybe I have the wrong idea of what it's like to do this residency because I was at this completely white community. And so I entered the surgical residency program at Montefiore after my first year as a pathology resident. And because of the difference in culture, I never felt from my attendings at Monty like I couldn't do it.
Yeah.
It's just a completely different world. And people need to know that sometimes different programs, different colleges, different high schools, different communities have a different perception of women and what they can do. And unfortunately, even though it's 30 years later, I think it really affects all of us, how we are perceived in these different roles. Either we feel like we can't do it, or we feel like people are going to interfere with our progress through this 5-year program.
Right. And I'll say or either we're going to be blocked or we're going to be ridiculed or we're going to be somehow disenfranchised or certainly prejudiced against being. Both of us, Zoe and I, are both petite women. I remember the one resident who I saw at St. Vincent's was this 5'9", beautiful woman. And I used to think, oh, maybe she can do it because she's tall. You
Absolutely.
just reduce the discussion in your own head to these simple things because you can't always wrap your head around all of the obstacles, all of the prejudices.
I think it's like a piece of armor because I used to say that when they used to tell me, you should do a vascular fellowship, they used to say, and they were a tough crowd, the vascular guys, and I would say, you know what? I can't grow 6 inches and get giant boobs so that I could run with you guys. So you know what? I'm going to pass on that.
Yeah.
I mean, you're not going to even listen to anything I say unless I have these giant boobs. So, like, why would I bother? Forget it.
I love that you have a sense of humor about it because I don't always have a sense of humor about it.
No, it's probably not that funny.
It's grotesque, but at the same time, now that we have years behind us after these difficult times, one can have a bit of a humor around it, but I think that it's not gone. I still face challenges in the contemporary hospital in which I work sometimes that is about my size or my gender or other issues that don't always feel like have anything to do with my medical capacity, my capacity to be a surgeon or to be a physician.
I agree with you. When I was a chief resident, one of the orthopedic residents, who was a woman, their only female resident, told me, I think it was her 3rd year, that she was quitting, that she was going into internal medicine. And she was awesome.
Yeah.
And I said to her, you're quitting? Please don't quit. And she said, I can't take it. I'm not going to spend one more year with these guys.
Yeah.
I said, but when you're done, you can do whatever you want. She said, I can't see spending the rest of my life with guys like this. And I was devastated.
Yeah. Yeah.
It was devastating. She was like a prize.
Yeah.
She was smart. She was competent. She was nice to the patients. And there are very few female orthopedic surgeons.
Right.
And I've never seen a female orthopedic surgeon who even does the same kind of cases that the guys do.
Yeah.
They'll do hand or they'll do sports medicine where they don't perform these big joint replacements. And you know what? I really have to think that they just get boxed out on every level. All these levels we're talking about, people don't listen to them. They don't get this feeling that they can do it. They don't get the encouragement. They don't have the camaraderie. You need all of this in order to make it. These guys are getting it, but you don't see it. They're getting it from each other.
No, it's the whole locker room mentality. And I'm grateful that these guys have support. They have community. They have the backslapping that helps them persevere because training in medicine is hard.
Yes.
No matter where, what, whomever. So to do it in isolation, I like to tell the story. I don't like to tell it, but it's so emblematic for me. I remember when I was in a large GYN-onc case that was on its 8th hour.
Yep.
And I had my period. And I asked to be excused. And I was just retracting. I was not participating as a primary or secondary assistant. And I asked to be excused because I needed to change my super tampon pad. I thought I had wrapped myself up entirely. And as I'm feeling blood dripping down my leg, and I asked the attending, can I be excused? And he said, no. I wanted to scream and shout, but I was a second-year resident. I had absolutely no clout, no power. I was the only woman except for the nurse who was handing the instruments in the room. And I just felt ready to scream. At the end of this long case, I take off my surgical garb and I'm stained in blood. And I have to walk out with it all over my pants. It's it was
terrible.
Oh, it was awful. But that's just emblematic, if you will.
It is.
So let's take ourselves out of that space because now we're doing general surgery for years. And then you shifted to doing more breast cancer surgery and breast health. Can you tell us about that shift, when that happened and why?
My first job outside of the city was in northern New York, and I was doing everything. I was doing vascular surgery, pediatric surgery, general surgery, and I learned to do endoscopy. And then I had a child, and one of the difficulties with doing general surgery all the time is that you can start an operation an exploratory operation and just never know what you're going to find and when you're getting out of the operating room.
No test tells us these things. Sometimes anatomy is not what the books say it is. Yeah.
Yes. And the vascular surgical patients are a little more complicated because the operation can go fine, but the patients are so unhealthy that after you're done, either what you've done doesn't work or the patient is acutely ill. So that adds these variables to the operation. And I think that when you're a young mother, or I wasn't even that young, I was 38, but when you're a nursing mother of an infant, you really want some predictability. I don't think you ever really get that as a physician who has a family.
Right.
Maybe they have it more now because the doctors tend to do more shift work.
Right.
Even you can find general surgical shift work, but we really didn't have that then. So I started to want to winnow down the kind of cases that I did. However, I never really wanted to lose my general surgical skills because even then there was a national shortage of general surgeons, especially in rural and semi-rural areas. So we've never had enough doctors in the community who can perform an emergency appendectomy or fix someone who has a hole in their colon.
Right.
So I never stopped doing general surgery, but I did stop seeing patients in the office in my clinic, say, who needed their hernia repair or needed their gallbladder out. I really stopped soliciting those kind of patients. And partly it happens because women really want to see women for their breast problems. So if you're in a practice of 3 men and you're the only woman, you're going to see all the breast cancer patients.
It just titrates that way. It just self-selects.
Yes, and I totally understand that.
Yeah.
And I don't know if it's true that a female surgeon cares more about a woman losing her breast, but sometimes I think that's the perception. I think that a lot of women don't want to get undressed in front of male doctors or young male doctors. I just think that there are all of these factors that come into play. Now, I had done basic science research in breast cancer, and I've always been intellectually very curious about breast cancer, the history of breast cancer treatment, radical surgery, less radical surgery, the biology of carcinogenesis in the breast, biological factors, environmental factors. So intellectually, I've always been extremely interested in breast cancer. And I think it just naturally turned into a kind of a full-time practice. I still operate on general surgical patients for the reasons I mentioned.
When you're on call.
When I'm on call.
At the hospital.
That's right.
Yeah. So one of the impressions I get from our peers and you who tell women all too frequently that they have breast cancer is, how do you protect yourself? How do you not go to these dark blue places over and over again? Or do you? This is hard news to share with women on a regular basis. What would you say about that?
I think that in my head, if I call an 85-year-old who has a really small breast cancer that's not going to affect her life expectancy, I tell myself before I call them all these good things about their cancer that I'm also going to tell them. And then I think that acts as some kind of buffer that I'm doing for myself and for, let's say, 50% of the patients. Either I'm pretending to myself, I believe what I'm saying, right? But no one ever wants to get a phone call that they have cancer.
Right.
I kind of front load myself with all of these details of their cancer that I know it's really going to be okay.
Right.
And I tell them they're going to be okay.
Right.
And then when I have to call a 27-year-old, I really have to tell myself, this is just fucking horrible.
Yeah.
It's horrible.
Yeah.
And then I can hear myself playing this game in my head. What is okay about this? You know what? Nothing's okay. There's just nothing you can do. There's nothing you can say. And the other problem is calling people on the phone. It would be better to have everyone come in 72 hours to get their results. I would know, I'm doing this biopsy on Monday. On Thursday, I'm going to have your results. On Thursdays, from 1 to 4, I'm going to see all the patients who had their biopsies on Monday. But you know what? I don't have time because I'm seeing 20 other patients then, and I don't know if I'm going to have their pathology back. And then the pathology needs special stains, and someone else has to look at it. Oh, it just doesn't work. It
Yeah.
doesn't work. Now, the old guys never called anyone on the phone. They made people wait. And if they waited 2 weeks, it was okay. No one wants to wait.
It's hard to wait for a mammogram result, let alone a
Yeah.
biopsy result.
So no one is
Yeah.
going to wait. And there is no way most of the time, unless you see, like you get a path report on a Wednesday, it's a 25-year-old. You see you have a cancellation for Thursday. You know you don't want to call them. You know they're going to bring their family member. And you actually have your staff call and say, Dr. Weinstein may have your path report. We know we have it.
Right.
By tomorrow. Can you come tomorrow at 1?
Right. Right.
And when we can do that, we do it. But
Right.
most of the time, it's completely impossible.
Yeah.
So I'm always calling people on the phone. And I'm using all this terminology. They have no idea what they're talking about. Sometimes I don't even, when they're calm, I have no idea what that means. It means
Right.
that they're just burying everything.
Right.
When they're hysterical, I'm not there. Could be
Right.
no one is there.
Right.
But it's better than having someone show up at your office by themselves and telling them that they have cancer. Now, if you call them and you say, you need to come in tomorrow, I have your pathology, you need to bring someone, I really can't discuss it. Like, you just can't do it.
No, it's for the listeners out there. You think that after all these years of doctors telling patients about difficult diagnoses, we'd have an algorithm. We'd have a way of doing this that is humane and efficient and effective and all the right things. And yet we don't, because the system is so cumbersome. There's so many pieces, as Zoe's pointing out. It's not just the biopsy, but it's the report from the pathologist or maybe a second opinion about the pathologist. And then it's about the schedule, because guess what? She's seeing 30 patients already that day, et cetera, et cetera. Even with, I can't tell you how many times I've had this conversation, Zoe, with my peers. All right, I've got difficult news to give this patient, and my schedule looks like this, and I don't want to call her because just the things you pointed out. She may be alone. I know this woman well enough. It's going to be too hard. She's not even going to hear me, if you will, or whatever. Or her mother and her sister just died, or
Right,
all the stuff.
or she's getting divorced, or her kid just went to college, or she
Right.
lost her job.
All the things that affect how we hear news, embrace it, don't hear news, et cetera, et cetera, et cetera. For all you listeners out there, please know that most of us are trying to do our best. We really are. We're trying to convey this information with heart and soul. And I think back at that vascular surgeon who you learned from that when you were a student, who just honored that this is really a hard part of our job, really hard. It never, ever gets easy, and it never gets mundane. It is difficult.
Yes, it's
Yeah.
difficult.
Yeah, yeah.
It doesn't get easier.
Not for
There-
me, it hasn't.
No, and there's really no way you can protect yourself from this information.
Yeah. And what we know when we deliver the news that you have cancer, I don't care whether it's a simple skin cancer that's not going to affect your longevity or a very serious cancer, all most people hear when they're first told is cancer. And everything else is blah, 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 blah. And I say that with great heart because fear, sadness, the logistics, all the things that go into the head when we hear that word just overwhelms the mind.
Yeah. The only thing I've learned to say that I think has helped is first of all, I say, I'm going to get off the phone, but if you think of these 10 things you didn't ask me, you can write them down and call tomorrow and leave me a time when it's good to call you back, and I'll call you after office hours. Or you can just bring them to the visit, or say it's someone who has a family member that's involved. Or if you want your daughter to call me or your son, they can call me and leave their number and I'll talk to them.
Yeah, you're talking about giving them a morsel of control. Because when we hear that diagnosis or any chronic disease diagnosis, diagnoses in general are hard to embrace. So you're giving them an opportunity to have some level of control over what happens next. Moreover, you're making yourself available, which is so good of you because not every doctor does. And again, for those of you out there listening to us, if you hear this kind of news, write questions down, demand that you be seen again. Your doctor should be saying to you, okay, we're talking to you about this today. We're going to talk about it again and again as often as you need to. And that you can slow the metronome. I always say that when people hear they have cancer, and I'm not talking about emergency, I'm talking about, okay, I've just received word that I have breast cancer. You don't have to take care of everything tomorrow, that there is time, not years and years perhaps, but certainly you have some weeks in which you can see your breast cancer specialist again. You could see an oncologist. You can see a second opinion. All these things can be done if it's going to give you more information, a better sense of who you want to do your surgery with or your chemo with, where you're getting to create an environment that you feel best in. Do you agree?
Yes, I agree
Yeah,
100%. I'm often telling patients, most of the time, this is not a surgical emergency.
that's right.
You can talk to me, you can get another surgical opinion, you can see the oncologist ahead of time, you can see the radiation oncologist ahead of time. And there are some breast cancers that are more urgent. And then I would tell patients, and I would tell you that. I would tell you, you really have to figure sometimes, unfortunately, you're telling patients you have inflammatory carcinoma of the breast, a breast cancer that's aggressive, that has to be treated up front with chemotherapy. Sometimes you're telling patients, I'm telling you this today. You're going to hear half of what I'm saying. I need you to think about where you want to be for this treatment over the
Mm,
next 3 days, because the next thing we have to do is we have to get you in with an oncologist.
right.
So sometimes, unfortunately, most of the time, patients have a lot of time, but occasionally patients really have to make decisions and you try to guide them. What's the next most important decision they have to make, and how can we in my office get you to that next step?
Mm.
It's tough.
It's a question I was going to ask, and you're already to answer. It's like, what do you do to help women prepare for their surgery? And it's interesting. I had a woman say to me the other day, if only someone had told me to bring my own pillow. Sounds simple or ridiculous, perhaps, in the face of a breast cancer diagnosis. But I think that what she was saying to me, I know what she was saying to me was, if only someone just gave me ways in which I could make sure that experience is as comfortable, predictable, caring as it could be. So, what are some of the things that you say to women, in addition to what you just shared, that might help them prepare for breast cancer surgery, for example?
Well, I think one of the fortunate things is that most patients are not having radical surgery for breast cancer.
And what do you mean by radical
I
surgery?
mean that most patients are not having their breasts removed.
Right.
So they're not staying in the hospital.
That's what we call mastectomy.
Right. So they're not having tubes coming out of their skin, which you have when you have a mastectomy.
Yeah.
And they're not having a long operation where they wake up disoriented or
Mm.
maybe sick after anesthesia. So most of my patients are having the cancer removed, which is a lumpectomy, and a lymph node biopsy, and they're going home the same day. So one of the ways, I know this sounds dumb, is that my best friend is a plastic surgeon, and she has performed a lot of reconstructive operations on my patients who had mastectomies. And she does a lot of these operations in a fancy hospital in Connecticut. And I must have seen a few patients who came in postoperatively and they were wearing these stretchy pink Velcro bras that Velcroed in the front
Mm-hmm.
and Velcroed at the shoulders and
Mm-hmm.
had adjustable Velcro on the sides, and then had these silk ribbon loops with the plastic loop that hung off them to attach the drains. So
Mm-hmm.
instead of taping people up and figuring out where to put their drains or giving them these crappy cotton bras, they had this gorgeous bra
Mm.
that's made by a very nice company. And I said, oh, look at these fancy bras they have at this hospital. And then I asked my hospital if we could get them, and they said yes.
Ah,
And I think they cost $80 each,
wow.
which is a big deal for a little community hospital that's
Absolutely.
struggling financially. And every person who has a lumpectomy or a mastectomy leaves with these bras that are stretchy and comfortable and adjustable and they're like small or triple XL.
Right.
And sometimes a year later, a patient will come from a breast exam and they'll be wearing this bra. They say it's their favorite bra. So that
Mm.
has a lot to do with just comfort.
Right.
It's pretty, it's
Right.
comfortable, it's washable,
Right.
it dries quickly.
Right. Right.
So I would say
Practical.
it
Yeah.
sounds trivial, right? But it
No,
isn't.
but that's what I'm trying to point out, is that if you are going for surgery for any reason, I don't care if it's your gallbladder or your breast or your pelvic region, these are the kind of questions you might be asking your doctor, or these are the questions you might ask your neighbor who you know went through the same surgery. Like, do you think it's silly that I bring my own blanket? Do you think it's silly that I bring my own pajamas? Do you think it's silly that I ask my husband to bring me my favorite tea? These are these creature comforts that can make any hospital stay or hospital experience more comfortable, and that you have every right to demand and know about, because these little bits and pieces are what give us a sense of control over an experience that feels so out of control.
Yes. And, we have an incredible oncology support
Mm.
program in Kingston. So the women who work in that program come to the hospital on the day of surgery, and they see my patients, and they usually bring them a handmade blanket that volunteers have made. They're usually crocheted. They have little pillows that they can use. We have little tiny pillows for people who have infuser ports, which are on the chest wall, that can be uncomfortable when you wear a seatbelt. They have all kinds. More
Lovely,
than that, they
lovely.
have emotional support.
Right.
They have group meetings. They can help. It's a good time for them to interface with you if you're having financial concerns.
Right.
They can get you Hannaford food cards. They can get you gas cards. They can help you figure out. Sometimes the operation is like this finite event that's in front of, that kind of heralds a year of difficult financial scheduling problems, especially for women with children. And that's a really good time for them to interface with the patients and really figure out what their stress level is and how we can get them some help.
Yeah. As we come to a close, what I want to point out, what Zoe's talking about, is something I say a lot on GynoCurious, is that we feel so alone when we're going through these medical procedures and hardships. And what Zoe's pointing out is that there are often communities, doctors, social workers, people in hospital settings that are there to help you get through it. And sometimes it takes a little bit of excavation to find them. Some people will find it on social media. Some people will find it as soon as they wake up. There's a social worker sitting at her bedside with all this information. But that, again, ask for help. Help is not because you're weak or you're unable. It's not a sign of weakness. It is a sign of strength to empower yourself with information, knowledge, and all of those opportunities to assist you in these journeys.
And remember, women are usually at the center of their own personal world. Women are frequently single mothers. Maybe the primary wage earner. They're under a lot of pressure. When they have a breast cancer diagnosis, it's a complete derailment.
Yes.
It is unexpected. It's nobody's fault. It happens. It's like an accident happening to them. And people really need help to get to the end of the journey, truly.
Yeah. Yeah, it's not your fault out there. It's so important that you hear that. Zoe, I can't thank you enough. There's so much we can chat about, but this has been just so enriching and important for GynoCurious listeners. So thank you for joining me.
Oh, it's my pleasure.
Thank you also to my listeners and to my producers, Jen Hammoud and Matty Rosenberg, and to the Epicurean for helping me make this podcast a reality. I would love to hear from you. Please email your questions and comments to comments@radiofreerhiniecliff.org or call us at 845-307-7446. Please give GynoCurious 5 stars on whatever podcast app you are listening on. And until our next conversation, be healthy. And please remember to relish your instincts and intuitions. They are great teachers, not to be ignored. Please be well.